Today, we're talking about arterial ulcers, how to recognize them, why debridement can actually cause harm, and what must be done before you can even think about picking up a curette. By the end of this video, you'll know exactly how to protect your patient, avoid the most common mistake providers make, and finally feel confident when faced with this high-risk wound. It looks like slough. It smells like infection. It's tempting to debride, but if you do it before checking one thing, you might make it much worse. Arterial ulcers aren't just wounds, they're warnings, and what you do next could save a limb. For those who don't know me, my name is Dr. Voltaire. I'm a wound care physician, and I've worked with patients where one wrong move, one early debridement, led to complications we couldn't reverse. This is the ulcer that changed how I approach every leg wound I see. If you're new to wound care, or even if you've been in it for a while and still feel unsure about when it's safe to debride, this video is for you. This isn't about fancy tools. It's about slowing down, seeing clearly, and making smart, safe decisions. Here's what we're going to cover: how to spot an arterial ulcer before you touch it, what's really happening under the surface, the simple test that should always come before debridement, and a real case where doing it right saved the patient's leg. And at the end, I'll share the #1 pressure point most people overlook, literally. Let's start with what you're seeing. An arterial ulcer is usually small, round, and painful. You'll often find it over bony areas like the tips of the toes, the outer ankle, or right over the shin. The base might look dry or black or have that classic yellow slough. It might even look like a pressure injury at first glance, but here's the key: it's starved of oxygen. This wound isn't getting enough blood, and then that means it can't build healthy tissue. So if you debride it too soon, you're not cleaning it, you're injuring it. Here's the problem: a wound that isn't perfused can't heal. If you remove tissue from an arterial ulcer without checking blood flow first, you might turn a dry, stable wound into a wet, infected one. You could trigger pain, bleeding, or even tissue death. You could push a patient into unnecessary antibiotics or amputation risk. I've unfortunately seen it happen. The wound looks so stagnant, someone debrides it. 2 days later, foul odor, spreading necrosis, and an emergency consult. Not because the wound was infected, but because the tissue didn't have what it needed to recover. So what should happen before debridement? Check perfusion, always. That means get an ABI, also known as an ankle brachial index. At the very least, check for palpable pulses, so the dorsalis pedis and posterior tibial pulses. An ABI below 0.8 means you slow down. Below 0.5, you stop. No debridement until vascular is involved. This isn't a delay, it's protection. It gives the patient a chance to heal without complications. Numbers are great, but sometimes you'll need to make a judgment before results come in. So here's what to watch for. The wound is painful, especially at night or when legs are elevated. The skin around it is shiny, thin, or cool to the touch. Hair is missing on the leg. There's a history of claudication or known peripheral arterial disease, or PAD. The wound is dry, not draining, and has a black eschar or a pale gray base. These clues mean that you should proceed with caution. Treat the cause, not just the surface. Arterial wounds still need pressure relief. If the heel is pressed into a mattress or the toe is rubbing a shoe, blood flow gets even worse. But instead of just offloading with foam, think positioning. Elevate with care, avoid compression unless you know arterial flow is adequate. In other words, be gentle and be smart. Let me tell you about a case we'll call Mr. D. He came in with a small wound over his lateral ankle. It looked dry, not infected, not draining, but it was painful. He couldn't sleep without dangling his foot off the bed. A new clinician saw it and, well-meaning, debrided it. Within 48 hours, it opened wide. The slough returned and the pain doubled. We got an ABI and it was 0.38. By the time vascular was involved, we were behind. He ended up needing a partial foot amputation, not because of infection, but because the wound had essentially collapsed. That experience shaped everything I teach now. So what's the better move? Keep the wound dry and protected. Add a non-adhesive dressing like Mepitel 1 or Adaptic. Monitor regularly and get vascular assessment ASAP. Also reassess every week for any changes in pain, color, or odor, and document everything, especially that you held off on debridement for clinical reasons. This is how you buy time safely while getting the right teams involved. Now let's say the patient gets revascularized, which is a procedure to help blood flow return to the rest of the leg. The stents are placed, ABI improves, pulses return. That's your green light. Now you debride gently with a goal. You'll see granulation finally begin. You'll feel like you're finally making progress because now the body is ready, and your patient, they're safer, more stable, more likely to heal. So remember, if it's arterial, hold the blade. check the flow, support the limb, get the right team involved. Because in wound care, sometimes doing less is what leads to more healing in the end. Thanks for watching. If this video helped you, check out my next one on why catching peripheral artery disease early makes all the difference. It's a lesson every provider should hear. Stay informed and heal well.